Learning virtual. Okay, let's start now. Hi, everyone. Welcome to our MyIBD Learning virtual program, Navigating Growth and Puberty for Kids with IBD. My name is Ella Bowker, and I'm a rising senior at the University of Washington. I'm studying biochemistry and molecular biology, and I was diagnosed with Crohn's disease when I was in eighth grade. I am so excited to be here with you today, so let's get into it. IBD can affect your child's growth in a variety of ways. We hope tonight you'll learn more about nutritional and physiological factors, treatment options, signs to watch for, and the role of having a multidisciplinary approach for your child's care and managing growth and development. Okay, so in order to make the program more interactive and find out how much you've learned tonight, we'll be asking two questions via a poll that should have showed up on your screen. So the first question is, what is the common early sign that IBD may be affecting a child's growth? Please pick one. And then the second question is, which of the following is true about the role of nutrition in managing IBD and growth? Again, please pick another answer. And we'll give everyone a few seconds to make their choices. And then at the end of the presentation, again, we'll ask these questions and see how much the group has learned. Hopefully, it's a little easier to answer at the end. Okay, cool. So we have the answer. They should have popped up on your screen now. So the first question, what is the common early sign that IBD may be affecting a child's growth? The 92% of people picked slowing or plateau in weight or height growth. And then the second question, which of the following is true about the role of nutrition in managing IBD and growth? Is nutrition helps with both growth and bone health, and that was 100% of people. So, all right. Now we'll move on. So this program is generously supported in collaboration with Improve Care Now. And on behalf of the Crohn's and Colitis Foundation and Improve Now Care Now, we really thank you all for joining. Okay, so the information shared is meant to be for educational purposes only and should not replace any guidance or advice from your own healthcare professional. Again, this program will be recorded and posted on the MyIBD Learning website. So everyone who registered for the program will receive a link with the recording next week. So if you want to watch this again, you can. We want this to be as interactive and engaging for you, so we encourage you please submit questions through the Q&A box, which is found at the lower portion of your screen. Following our expert discussions, I will moderate a Q&A session with all of our panelists and will address as many questions as we can at that time. Okay, so tonight's speaker. Tonight we have the opportunity to hear from Dr. Jennifer Dotson, a pediatric gastroenterologist. Jennifer Dotson is the Chief of Pediatric Gastroenterology at Arkansas Children and professor at the University of Arkansas Medical Sciences. She specializes in pediatric inflammatory bowel disease, or IBD, blending clinical research, quality improvement, and advocacy. A leader in organizations like NASPGHAN, the American Academy of Pediatrics, Improve Care Now, and the Crohn's and Colitis Foundation. Dr. Dotson is also a founding co-chair of ICN's Clinical Standardization/Personalized Care Learning Lab. She serves on editorial boards and national committees, guiding research, policy, and mentorship. Her work is driven by commitment to health equity and advancing care for children with IBD. We also understand the importance of your questions, and we want to ensure we have as many of your questions answered as possible. So tonight, we also have the honor of having Dr. Joseph Picario monitoring the Q&A box. Dr. Joseph Picario is a pediatric gastroenterologist and the director of the Pediatric IBD Center at Columbia University Medical Center, New York Presbyterian Hospital. He is dedicated to delivering compassionate, comprehensive healthcare using advanced diagnostics, targeted therapies, and a multidisciplinary team approach. An accomplished educator and national leader, he currently serves as the chair of the Clinical Care and Quality Committee of the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, or NASPGHAN, like we mentioned earlier. He has advanced training in interventional endoscopy and intestinal ultrasound, incorporating innovations in endoscopy and in disease characterization to advance the care of pediatric IBD. If you have a question for Dr. Picario, please type it in the Q&A box. He will do his very best to answer as many questions as he can, keeping in mind he may not be able to address every single question. Again, following Dr. Dobson's presentation, Dr. Picario will join her for a live Q&A session. We do not have any speaker financial disclosures. And now we can get started with tonight's presentation. At this time, I'd like to welcome Dr. Jennifer Dotson.
Thanks, Ella. Thrilled to be here tonight just to talk with you, just to share a little bit about growth and puberty in kids with IBD from a perspective. So here's just an outline of what our goals and what we're going to kind of cover over the course of this webinar. So we're going to overview just what normal growth and puberty looks like in children and adolescents. We want to understand how inflammatory bowel disease can impact growth and puberty. Look for some signs that you can watch for and learn a little bit more about how treatment helps with growth and puberty and issues that we might run into. So we'll go into that a little bit more detail. And then also discuss the importance of really having that multidisciplinary team to make sure that we're checking everything. So first, we want to talk about what to expect for growth overall, just normal growth and development. I do first want to acknowledge that when we're referencing male and female throughout this through this discussion for this webinar, we are talking about male and female based on sex assigned at birth. So here you can see just two pictures here. And so this is just two examples of normal growth charts. This is a common one that common form essentially that we use in pediatrics. And so we have these normal growth patterns that are established, and through a bunch of statistical tools and a lot of observations over many years, these are constructed and put together. So we have charts from the Center for Disease Control as well as the World Health Organization charts. And so these are the common ones that we use in pediatrics, with the blue side being for boys, red, and that pinky kind of red color there for girls. And so this looks at percentile curves for weight, height for children. And we have each separate growth charts for boys versus girls, because there are some differences as far as like timing and growth spurts that we see. But overall, you can kind of see how there's this slight little curve and then these little bumps and kind of like a little like higher sort of a little growth spurt sort of area that pops up there on the growth charts. And these are just really helpful for both your pediatrician at regular health checkups to be monitoring growth throughout childhood, as well as for your gastroenterology team to make sure that you're growing appropriately throughout your disease course. And so these are the things that we're automatically checking. One of the important parts related to this is you'll kind of see like there's a like upper and lower line on these. And so the bottom kind of thick bold line for both of these charts is the 5th percentile, and then the top line is the 95th. And so essentially what these charts show is if you essentially took 100, say, girls that were age 10, and you were seeing we were seeing you, and you were at the 50th percentile. Essentially, that would mean that 50 girls would weigh more than you, 50 would weigh less than you, or 50 would be taller than you, and 50 would be less than you. And so that's what these percentiles mean. And there's a spectrum of a lot of different shapes and sizes of different bodies. And so, so there's a spectrum of what's normal on the growth chart, but there's a wide variety there. So, the most important part is that we follow the trend, or these trend lines over time. So one point in time isn't as important as following that trend. So if you were always around the 50th percentile and now you're crossing those percentiles and you're at a lower percentile, then we get concerned, as opposed to if you were always at the 5th percentile and kind of following your curve. That's a different story, right? And so these are, like I said, helpful tools that you may or may not have seen just through your regular pediatrician appointments or your GI appointments. And then next, we want to talk a little bit about an overview of just regular puberty. So this process starts with the brain. And so the two main parts of the brain are through the hypothalamus and the pituitary. These are two specific areas of the brain where that start making certain types of hormones that trigger your ovaries and testes to really start releasing those chemicals that are responsible for puberty in your body. So for girls, typically starts a little bit earlier than boys, so somewhere between the age of 8 and 13. And then puberty typically will end for girls around 15 to 17. For boys, like I said, it's about a year later for those same time points. And so the figure on the left just shows, those basic aspects of what to kind of expect for normal puberty. And that we see growth spurts, breast development, changes in that body composition, hair, period starting, those types of things. And for boys, seeing changes as well with lean muscle mass, for example. The other important part of puberty is like, how do we assess that as pediatricians? So the way that we assess that is through kind of like a visual that we'll talk about on the next slide. That's called Tanner stages. And so these stages, essentially, the entire course of puberty is broken down into 5 stages. So from early childhood through full maturity, and that's based on physical development on those secondary sexual characteristics. So we'll talk about that here on the next slide. So on the far left side of this chart is males, and then the right 2/3 is the female part of the chart. Kind of all thrown together in one figure. So on the left-hand side, you start from Tanner stage 1 as being the more child or prepubescent child, and then working all the way down to the Tanner stage 5, which is full adult maturity from Tanner staging. So you can see there's gradual progression of several things there on the male part side of the chart. So both increases in the testicular volume or size of the testicles, as well as hair starting to develop in that region, and then expanse of the hair, and as well as the enlargement of the penis. Now, when we look at the right-hand side of the chart, this is looking at how girls develop through those different Tanner stages, ranging from the prepubescent to the fully mature female, with the distribution of hair in the genital area, as well as the breast development and how the breast develops. Just the elevation of that initial dual papilla on the chest, to full breast development. And so this is a helpful a chart to keep in mind as far as, where kids are at certain stages and what the expectations are by certain ages. So this is something that your pediatrician is routinely monitoring at your regular checkups. And then sometimes these are going to be asked at your GI doctor's office. So we may, ask, and so sometimes they may be examining these in your GI office. Sometimes we'll also just ask the patient to describe on a picture and kind of point out where things are. And these are also sometimes something that we'll look at when we're doing endoscopy. So it's a little bit more of like a private exam time as well. And so when we have concerns related to Tanner staging and puberty development, it kind of depends on whether you're male or female. So for girls, if you don't have that initial stage 2 development of those breast buds by the time you're 13, or if you haven't started a period or your menses within 3 years of that stage 2 breast bud stage, or you haven't started your period by the time you're 15, then we start getting a little bit concerned about delays in puberty there. And then for boys, if there's not stage 2 genital development starting by age 14. So next we want to talk about how IBD can affect growth and development. So we know that both height and weight can be impacted, as well as puberty and those different milestones at those different stages. And especially for patients that are diagnosed before those early stages of puberty start. So, so if we have a prepubescent child that is diagnosed, we may see delays in their puberty. So kids will potentially appear younger than what they actually are for their chronologic age. This growth impairment that we see is really a marker of active disease or disease-related complications in patients that have inflammatory bowel disease. And so this is one of the first things that we look at as pediatric GI doctors, is what's the impact of growth and how concerned to be. And we do see this quite commonly, at least some degree of growth impairment. And I'm talking about growth kind of loosely as far as like both like height and weight. When we're looking at this, we see this up to about 80% of patients with Crohn's. And the impact of IBD on growth and development depends on a whole bunch of different factors. It can depend on the type of IBD you have, as far as Crohn's versus ulcerative colitis, the extent of your disease, the severity of your disease, as well as complications associated with your disease. So one of the common ones being strictures, for example, in Crohn's, and how that can impact growth as well. The other aspect of this is the issue that we have related to active disease or disease flare-ups, and sometimes when you're just not feeling well, or you notice that there's certain food intolerances or trigger foods, and so sometimes that can also impact growth and development, and the amount of intake that you're eating from those sources of those nutrition. So sometimes the food intolerance and trigger foods can be an issue too that is contributing. Next slide. So when we talk about our skeletal development, so this can also be delayed as part of that process with just normal growth and development, part of that puberty process. And so there can be a delay in closure of the growth plates of the long bones in your skeleton. So these are, the big bones in your arms and your legs. And so these areas of the growth plates are where you're building that increased bone and especially that height. And so if those plates are open or kind of delayed longer, then that you do have that continued growth potential, as opposed to somebody whose growth plates are already closing or are at that process of closure already, then we know that there's not going to be additional growth or growth potential after that point. And so sometimes you might talk about that with your medical team. We'll talk a little bit more about that later, about checking like a bone age and kind of seeing where you are, how much additional growth potential there is. We know that chronic inflammation plays an important role in growth and development. So one of the main drivers for this is a chemical TNF alpha, or tumor necrosis factor alpha. And so for anybody that is on like infliximab or adalimumab, those are medications that specifically target one of the most common pathways of inflammation in IBD, which is the TNF alpha. And so it's not a surprise that this is one of the key factors that is driving some of the inflammation and will impact and potentially slow or suppress growth. The other huge category of this is just poor nutrition that comes along with for a lot of people that have inflammatory bowel disease. And this is related to malabsorption, or just not absorbing those nutrients just because of the inflamed bowel, the appetite loss of just, not feeling great, not really feeling like wanting to eat just because of symptoms, and also just all that chemical process of that, all those inflammation chemicals and stuff in the body that just makes you not feel good and not want to eat, as well as just increased energy needs during that time period with all this inflammation and stuff that's going on. The other important aspect is around for females with their menstrual cycles. So some patients will, like we talked about, puberty delays, and that can be a part of this. They may have a delay when they actually start their first cycle or their first period. And then some teens will notice that they'll have irregular periods. And so this might happen at time of diagnosis, or at times potentially of disease flare-up. And it's the hormones as well as your nutrition status and just stress that play a role in that, and that can cause you to potentially like skip periods or have those more irregular periods. So it's not uncommon for us to see issues with growth and development, or have our teen girls complain about like irregular periods and things like that come up, especially during the times of active disease. I think the most important part is, obviously, being able to, diagnose early. So shortly after symptoms are starting, we're able to get an early diagnosis and get patients started on treatment right away. So really that appropriate management right up front plays a huge role in the growth and development, and making sure that we keep kids on track for the appropriate puberty development as well. And it's very important that we monitor the overall just nutrition status of our patients and the growth status, both in the GI office as well as through your pediatrician's office too. So it's really important to partner between the two groups. Now, when we look at nutritional impact of IBD on growth. So you're catching on to the theme that growth is really a driver related to inflammation, that malnutrition, as well as these micronutrient deficiencies that can also happen. So nutrition directly impacts both growth and your bone health, so that it plays a critical role in that bone health, which we'll talk a little bit more about in a minute. And so we often, when we see issues related to growth, we typically will see issues on the weight growth curve part before we see it on the height growth chart part. So typically we'll see either a decrease in weight, or we will see when we plot through your points out on the growth chart that we might see just like a plateau or kind of leveling off. And when we see that leveling off over time, really what you're also seeing is that change in your percentile. So say that person that was initially at that 50th percentile, maybe they're still at, weighing whatever, 90 pounds, for example. And if they don't lose weight, but they just stay at 90 pounds for the next year, they're not gaining, and their percentile then starts decreasing. So even though there's no weight loss, they just kind of plateaued. So they went from 50th to 48th to 45th. Now they're at the 30th percent. So you gradually kind of see how that can happen over time. And then we'll see the height get impacted after that. And then the kind of the reverse happens once we start treating the disease, getting the disease under control, giving appropriate nutrition, and you're having appropriate absorption of those nutrients. You'll see weight gain or getting back on your previous growth curve when you were healthy and your disease was in control. Those percentiles will bump back up, and then you'll see for your weight, and then you'll see the same thing that start happening again with the stature, your height growth charts. So we know that the chronic inflammation, as well as the stricturing related disease, like with Crohn's disease, for example, can impact your nutrition status. And so your disease itself can cause issues just because of just the symptoms and stuff that you're experiencing. So just abdominal pain and having decreased appetite, or being nauseous, or having diarrhea, and just having to feel like to go to the bathroom shortly after you eat, and where it kind of just goes right through you, and all of those sorts of feelings and experiences and stuff that you have around eating that can decrease the amount of food or the calories that you're taking in. And then you also have the issues related to those what we call like those obstructive symptoms, or those bowel obstructive symptoms, particularly for patients that have Crohn's disease and have strictures, where typically what happens if there's a lot of inflammation and you develop the scarring or the strictures in the bowel, patients can have issues with just bloating, or that abdominal distension where your belly looks kind of puffed out and kind of bloated, or real gassy, or you might feel nauseous or have more severe belly pain, or even vomiting shortly after eating. And so those would be some concerns for, is there some sort of obstructive symptoms or something like that that's going on? And so certainly that can impact, nutritional intake and your overall growth. And then malnutrition, typically that will result just from decreased absorption, and then those dietary restrictions from all those different causes that we were talking about. And so mainly it's due just to not getting in enough calories during those flare-up times. And the biggest bulk of that is from your macronutrients. And so those are all your proteins and fats and carbohydrates and things that you need from your diet that are really essential for growth and development, all of your essential energy essentially that you need in your body's metabolism and how things function. And then you also have all those micronutrient deficiencies as well that can be playing a role. And those are also incredibly important. So this is, why we check to make sure about anemia and iron deficiency. And so iron, zinc, vitamin D, vitamin B12, calcium, folate. So those are really common ones that can be impacted as far as from the micronutrient standpoint for inflammatory bowel disease. And often some of those we check more often than others, depending on your clinical scenario. But those micronutrients are important for certain types of enzyme reactions within the body, as well as immune function, and then certain types of little signals that happen across cells and across tissues, and how it communicates in our body. So those are really important. And then I included two links here too on the slide related to some additional information around like diet and IBD with Improved Care Now on their website. That's great, as well as some of the information from Crohn's and Colitis Foundation too on diet and nutrition, as well as some gut-friendly recipes and some other things too. So I think there's a phenomenal wealth of information from a nutrition standpoint on those websites. Now, when we look at the nutritional impact of IBD on growth, I stressed how important it is that we monitor these, both the height and the weight, and looking at your micronutrient related deficiencies to really optimize your growth outcomes. So we always check, your weight and height at your routine office visits when you're coming into GI. That's why your pediatrician checks those things. I think it's also really important, especially sort of, post-pandemic. I feel like more practices are still offering a lot of telehealth services, which I think is great to improve access and convenience for our patients. But that's one of the things that we sometimes will miss when we're doing telehealth. So I think, making sure at home that you're, still, periodically monitoring that, to make sure that we're still doing okay from a weight standpoint, and definitely let us know if you notice any concerns. And then the growth charts are helpful, like I said, for both the height, the weight. We also look at body mass index, or that ratio of your weight and your height together, as well as your height velocity, which is kind of like the rate or how quickly those little growth spurts are that are happening. And then the routine blood work is also important. And so this is where we'll look at for anemia, or their low blood counts, which typically in most of our patients with IBD, you have chronic microscopic sort of blood loss that's going if there's inflammation, and you can have that can lead to iron deficiency or low iron stores that can contribute to fatigue as well. And then your vitamin D levels. And so oftentimes we'll check this a couple times a year too. So we know that vitamin D deficiency is common for patients with inflammatory bowel disease. And then there's those other micronutrients I mentioned, and some of those are a little bit more specific depending on where your disease is located and if you've had resections and things like that. Some of the other labs will check a little bit more often. And then there's also, I wanted to spend a little bit of time talking about the role of exclusive enteral nutrition, or EEN. And so this is particularly important for patients with Crohn's disease, as you know, this is that exclusive sort of nutrition shake therapy that can put patients and a disease into remission and control the disease, as well as correct malnutrition. Some of our patients will do this for both kind of that initial kind of put the fire out sort of part of the flares, and some patients will continue it for like their maintenance plan. But it can be tough to do, just more of like that exclusive enteral nutrition for treatment. But sometimes we'll also use it for patients if they're as like a bridge therapy, if they have an infection and we can't use some of the other medicines that suppress the immune system, or sometimes if there's malnutrition and other types like abscesses and those types of things. Sometimes while we're waiting to be able to restart their biologics, sometimes we'll use the EEN as a kind of like a bridge therapy to both treat their Crohn's and the malnutrition that's happening related to the surgical complications to stuff that they're having. And then even if patients aren't doing, the full nutrition shake therapy where most of your calories are coming from those nutrition shakes, even partial enteral nutrition can be helpful from just helping from that macro and micronutrient deficiency aspect. So if you're underweight, if we've lost weight and flare-ups, so sometimes your medical team will recommend adding those nutritional shakes just to help supplement a little bit from a nutrition standpoint to make sure we're meeting all those needs. Now, when we talk about IBD treatments and how those impact growth, there's a wide variety here. So steroids or prednisone, so this is probably one of the worst medications that we use to treat IBD, is great at helping to reduce the inflammation and getting you feeling better quick, but it's really good just to kind of help, like I call it, say, like kind of put the fire out. It's not something that we will want to use as an ongoing maintenance therapy just because of the long-term issues and all the side effects associated with steroids. But it does impact growth, especially those prolonged courses of steroids. And the steroids can also cause issues with delays of puberty, and then also increases your risk of more weak bones, which can lead to more of the osteopenia or osteoporosis if we're on steroids long term. And then some of the other medicines that we use, such as methotrexate or thiopurine. So these are older medicines that we used like several decades ago as more like first-line therapies for inflammatory bowel disease before biologics came on the market, kind of like in the late 90s. And so they tend not to have much of a direct effect on growth. They don't really help. They don't really hurt that much, just because they're overall, those medications by themselves, are really not that helpful for a treatment for IBD, with outside of like a small percentage of people will respond potentially well to those. So we tend not to use those as much as part of like our routine practice, especially in pediatric IBD. We tend to use a lot more of the biologics because these are the medicines that are like, there's a whole bunch of them now on the market, but the oldest ones that we use and the most common ones that we use are the anti-TNF alpha drugs, the ones that I mentioned earlier, that are infliximab and adalimumab. And so these are really helpful for that potential for that catch-up growth, and they can really restore that growth or that missed potential growth in our teens. So these are great sort of quick-acting medications to really help control that inflammation and get you into remission, get you feeling better, and get growth back on track. I also want to make just a couple notes on a couple things that come up related to other types of medicines and over-the-counters and some interactions. And so I always think it's important that we're aware of these things. And so one of the drug interaction, the discussions that often comes up is related to like Accutane or the isotretinoin, which is a medicine that's commonly used for acne by both pediatricians and dermatologists. And a lot of our teenagers are having to battle with the acne. And so from our standpoint, it's fine and safe to use. It does not impact growth of IBD. And many studies have now shown that there's really not an association between the use of Accutane and overall risk of developing IBD or flares. And so if you need it, it's okay to use. And then I think it's also important to talk about those nutrition or those different types of nutrient and sort of drug reactions. And again, talking about there's a whole variety of things that kind of fall into this bucket. And so it's really important to let your physician know, as well as potentially like your pharmacist or even your dietitian, that if you're taking other over-the-counter medicines, vitamins, other minerals, or herbal supplements, a lot of them are safe or fairly safe. But there are some that can interact with potentially your IBD related medications or other medications as well that you may be taking for other medical conditions. And so sometimes what we see with some of these, like different types of over-the-counter or herbal supplements is, differences in bioavailability as far as the amount of the active part of that supplement within that pill can vary depending on brand and manufacturing processes and things like that. There's also really a lack of standardization of those types of supplements because they're not regulated. They're not regulated by the FDA. So it's hard to know sometimes what is in them or other additives and things like that. And there's not as much research into the efficacy of these types of medications as well, or potential issues related to adverse events or side effects or reactions or interactions. So some of these things we know just from studies over time and kind of monitoring patients, but so just, like I said, most of them are probably okay, but just if you're using them, making sure that you're just letting us know, so just so we can make sure that whatever you're using is safe and potentially not putting you at any increased risk. Like I mentioned, some of these can impact metabolism or drug levels. And so some are related to potentially mental health related medications. They can impact those, or seizure related medications, and some others. And so those are common ones that can be impacted by certain types of supplements. And some of them that can then either decrease the efficacy of those medicines that are prescribed to treat certain conditions, or they can increase the risk of having like high levels of those medicines and potentially cause harm or side effects related to those. Next slide. The other important aspect that I want to talk about is related to surgery. And so I think of surgery as just another treatment in our treatment armamentarium when we're talking about how to best treat IBD. And just because we do surgery doesn't necessarily mean that that it's a bad thing. Sometimes surgery is very appropriate, and we need to make sure that we think of that not necessarily as a last resort or a failure or that type of thing. Sometimes that's just what we need to do in order to take the best care of our patients possible. And it's best used, I think, in conjunction with your medical therapy and your medical treatment plan, and everybody kind of partnering together with the medical decision making for that process. And the timing related to surgery really varies. For some patients, it may be best to have a surgery early on in the disease, depending on what's going on, such as a stricture either a stricture that's impacting symptoms and nutrition, or potentially a really stubborn segment of disease that we're not able to get under control with our other medicines. Sometimes the best option is to do resection, or for patients that have had a lot of struggle with like abscesses or things like that, potentially they may need a resection. So there's a lot of different reasons why patients potentially need surgery outside of just the medicine isn't working. So we're also treating the complications related to that. And then many of our patients will end up needing surgery at some point in their lifetime, with a disease. And so ultimately what we want to do is diagnose early, get the disease under control early, and try to essentially, delay the time to when those surgical complications would potentially evolve or develop. And really our goals around surgery are trying to either decrease or completely get rid of the symptoms that you may be having, especially if you have, for example, the stricture and symptoms related to that. But we overall want to improve your overall general health, your overall nutrition status, your growth, as well as that puberty or that sexual development aspect. And our goal, surgeon's goal, is to preserve as much as bowel as possible. So when we do surgery, we want to make sure that we're only removing the amount of bowel that we actually seriously need to remove. We don't want to be having repeat surgeries and multiple resections, because then we have less bowel surface area. Then that also leads to more issues of potentially nutrition related issues, malnutrition stuff, if not properly monitored and treated. Next step. I think one of the other aspects that I wanted to get into is a little bit more about the role of our multidisciplinary team. And so there's a huge impact for psychological stress and how that impacts growth and development. And so we know that increased and prolonged stress can have a really negative impact on the disease. And it's this stress that happens related to just having a chronic disease, and there's increased in levels of cortisol. It's kind of like a stress hormone in the body, and so it's like a steroid, similar to like we were talking about related to prednisone. Works a little different in the body, but that can impact or kind of stunt growth. And then we also have a mental health related component with like anxiety and depression, especially among teenagers. And we know that up to about a quarter of our patients that have inflammatory bowel disease will have some degree of anxiety or depression over the course of their disease. And just having anxiety depression itself can also impact your appetite and change your eating habits, and also impact adherence to your medications. And so, that can certainly drive that inflammatory response, lead to nutrition. And so it's a really important aspect that we need to make sure that we're taking care of the whole patient. There's also a significant social impact related to delays in puberty and height, as you can imagine. So obviously growing up, and especially in our like middle school and teen years, it can be really challenging for parents and caregivers and adults on the call, just reflecting to your own childhood and kind of going through that experience. But just then imagining, going through that with a chronic disease, and then potentially having, either delays in puberty or your height being stunted. And so, this is, relevant for both boys and girls. I feel like I get a lot of, questions and concerns, especially from our boys when, they're one of the smallest boys in their class, and how that impacts them and their social groups. Sometimes bullying can happen, and as well as our girls with, delays in puberty, and then not having, your periods when your social groups and things, the other girls that you're associating with are already had their periods, or they're already developing as far as like their breast development, and you're having those delays, and that can be very self-conscious, and have impacts on your overall body image concerns. And so it's really important to recognize, if you and the patient, or those on the call, or parents, if you notice that your child is having some of those feelings and feeling different from their peers, or noticing some of those body image concerns, and that you bring those up with your with your physician, or your advanced practice provider when you're seeing them in GI clinic, just to make sure that we have social work and psychology also pulled in there, and how they can help with addressing those issues, providing some guidance around those topics, go through some things related to coping techniques, and then also give you other types of resources to really help navigate that process. And so I think a really great resource is on the Improved Care Now website. And there's a variety of different toolkits that are available on their website that are completely constructed by our Patient Advisory Council within Improved Care Now. And so this is a group of teens and young adults that have IBD, that from their lived experience help develop different types of tools to help educate and provide support to other patients that are living with IBD, that are teens and young adults. So there's a lot of really great information there. So if you're struggling with that, I would really recommend that as a resource too. Next slide. So as far as warning signs, things to watch for in yourself or in your child, is looking for those changes in height, or the height velocity, or their weight or BMI curves. So as we're doing checkups in GI clinic or through your pediatrician's office, or if you start noticing the clothes are looking a little bit looser, or you're monitoring their weight at home at your home scale, and you notice some changes there, definitely bring those up with your team. And again, these are issues related to not just weight loss, but just slowing of weight and weight gain over time, slowing of the stature, as well as that plateau. We're just like, yeah, they just really haven't been gaining weight in a while. Those are also concerns. So it's not just weight loss that we get concerned about. And then if you notice any issues related to a delay in those secondary sexual characteristics that we were talking about with puberty development, that's Tanner staging. And so if there's concerns where it's just, that they just look a little different or maybe not as mature as some of their peers, or, things that you might be watching or discussing with a pediatrician, I think it's important to make sure you're looping us in on that as well. And again, the lack of periods. So if we haven't had the periods by age 15, then, definitely letting us know or your pediatrician know about that. And then the other, signs and symptoms related just to active disease, so watching for that fatigue and issues with appetite, abdominal pain, things like that, that are especially impacting eating and the amount of nutrition that you're able to take in, because we know that's going to impact growth and development. And then one of the other important topics I wanted just to hit on is the role of growth hormone and when do we get endocrine or the endocrinologist involved and when do we need those referrals. So there are some sort of like set parameters on that as far as like if there's, not progression in puberty or, if we see certain impacts of height velocity, if we're not quite hitting those certain parameters and we'll refer. One of the things that your pediatrician may do or your GI team may do is do bone age testing. And so those are just like simple x-rays to kind of look at if those growth plates are open and how your that bone is forming, kind of progressing based on age. And so that was kind of like I talked about earlier in this webinar about how kind of where's that window and how much catch-up growth and where we are in kind of that spectrum. Sometimes that can be helpful. Sometimes there's also some labs that will check, so if there's underlying thyroid issues or some growth hormone issues, some other things, sometimes we'll check some endocrinology labs. Personally, in my practice, I don't check a ton of those endocrinology labs when there's significant issues related to growth or bone age. I always like to pull in my endocrinology colleagues and have them do a consult, and they may or may not check labs or, but they usually end up checking something and checking like the bone age and stuff and making some recommendations. Most of the time, their recommendations are usually let's control our active disease, and that's usually what we also recommend from your GI team standpoint too. So most patients don't end up needing growth hormone therapy. It is expensive and time intensive. It involves a lot of shots. It's a lot, and sometimes it's a very it's a very hard commitment, to do that. And I think it's best as a shared decision-making discussion with the endocrinologist to really decide if that's really what's right for your child, and should always be directed by an endocrinologist, pediatric endocrinologist. And the most important part related to any of this, if anybody's having any of those concerns related to growth hormone, etc., is, have we ruled out active disease? That's first and foremost what we need to do, because we know that has such a huge impact. And most of the time, once we correct the active disease, get things into remission, then the growth improves and the stature improves as well. So we always want to assess that and treat that part first. And then as we talk about growth and development, we have a very important role for that multidisciplinary team, like I was mentioning. So your patient should always be at the center of this. We have your IBD nurse or IBD nurse coordinator, making sure you're keeping them in the loop for concerns, giving them a call or shooting them a patient portal message on the chart, keeping them in the loop on things if you have any concerns to pass along to the rest of your team. Definitely talking with the dietitian about any concerns with growth and in weight, and nutritional status related things, and then having your psychologist or social workers on your team. So some teams will have both or one or the other, but they're a really important part of coping and adjustment and stress and all of those things that I mentioned earlier. And then of course your GI physician or advanced practice provider, that's part of that too. And then sometimes the endocrinologist on the team. And so really it's that coordinated care of, the patient and the family and these sort of like critical players here as far as from a growth and nutrition standpoint, and how that impacts our growth and mental health and medication adherence that is really important. The other aspect of this is just making sure that we're monitoring everything. So a lot of things that we need to do is just that routine monitoring part, just your regular blood work, your disease monitoring for disease activity. And so those are the things that we check with labs and your inflammation markers and your calprotectin, or sometimes we might need to repeat like an MRI or an abdominal ultrasound or those types of things to monitor disease, or repeat scopes. And then routine growth monitoring. So your routine labs, your disease activity, your height, weight, all those things, that should be happening about every 3 to 6 months or so. And certainly more often for patients that are having active disease or significant changes going on. Next slide. So our big tips are kind of, some of the takeaways, making sure that we're keeping track of growth and those growth records. So you're kind of keeping an eye on that at home. We really want to make sure that we're prioritizing nutrition and rest. So that's important for healing, growth, development. Making sure that we're talking about stress and body image. So that's an incredible part of coping with a chronic disease, especially one that can impact your appearance. And these are not taboo topics, and so talking about them is incredibly important. And so finding, a trusted adult to talk about, or talking with your medical team. And some patients feel more comfortable just talking one-on-one with their medical team too. So sometimes that is more helpful at some of those visits. We want to make sure that we address any mental health concerns. Like we talked about anxiety, depression, body image issues, all those types of things overlap with that. We want to make sure we don't delay puberty workups, and that if there is concern for delays at puberty, did we assess for that active disease? Making sure that you're staying engaged with your care team, those follow-up visits, that routine monitoring. If there's questions, concerns, those types of things, always ask. Next slide. So our sort of summary, kind of take-home messages, is that growth and puberty are very sensitive to inflammation and nutrition, especially for patients that have inflammatory bowel disease. It is possible to have some catch-up growth depending on where we are with bone age, and where you are in that spectrum of diagnosis and your active disease, and where you are in puberty and that whole growth continuum. And then make sure that we have that routine monitoring, and then really focusing on that multidisciplinary team-based care. That's essential. And then we want to make sure that you always feel comfortable speaking up if you have any concerns in your child's overall care plan or the growth and development, and just make sure that you let your team know so we can better support you. I also wanted just to highlight a handful of resources. I mentioned a few as we were talking about. So these are 3 great ones. So the Crohn's and Colitis Foundation has a ton of information, ranging from things for younger children and our youth and young adults, as well as older patients. And so this was just a quick screenshot of just some of the topics that are available on the website, but there are some things related to puberty, menstruation, pregnancy, other things that are really important, nutrition. I mentioned some of those nutrition related resources earlier. Improve Care Now, they have a ton of resources, including, just like information related things, as well as actual like toolkits from the patient experience around body image, some things around disordered eating. There's a lot of information on there about nutrition as well that our dietitians helped with. So there's a lot of great resources to check out there. And then NASPGHAN, that's a mouthful. That's the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. So that's our pediatric GI group that many of us belong to. And they have a lot of resources on their website. Some of them are more like professional or clinical folk kind of driven. But the patient-facing side of it is called gikids.org. And so NASPGHAN supports all the material that is on there. And so there's a section for inflammatory bowel disease there as well that has a lot of great resources related to IBD that might be helpful. And I think Ella, we're into questions now. So excellent. Thank you.
Okay, thank you so much to Dr. Jennifer Dodson for the informative presentation. And so before we get in the Q&A, we'd like to bring up again the 2 questions we answered at the beginning, just to see how much everyone has learned. If you can go ahead and answer question 1 and question 2 again really quickly. Okay, awesome. So this is great. The correct answer for our first question is slowing or plateau in weight or height growth. So we've learned that another warning sign could include delay in secondary sexual characteristics. And then our second question regarding the role of nutrition, the correct answer is nutrition helps with both growth and bone health. So overall, you did great the first time and the second time. So thank you for helping us answer those polls. So now we'll direct a few of the audience's questions live to our expert presenters. I'd like to welcome Dr. Joseph Beccario on camera, who's been answering questions for us throughout the chat, but now he'll be with us. So if you have a question for Dr. Dotson or Dr. Beccario, please type it in the Q&A box, which can be found at the lower portion of the screen. So we'll begin with question one for Dr. Dotson. At which age should I start having conversations with my child's doctor about potential delays in growth and puberty?
Yeah, so I think from a growth standpoint, I mean, this is what we call like kind of that bread and butter thing that we do in pediatrics, so we're always monitoring growth, both, weight as well as height, and body mass index, throughout childhood. So that should be a topic that's coming up at all those kind of annual routine checkups with the pediatrician's office. So I think if there's ever any concerns, definitely always bring them up. And your pediatrician should be saying at those annual visits and stuff as well as like, yep, everything looks normal. Do you have any concerns? This is where I would expect them to be, and help provide more information stuff around, growth or puberty that's specific for your child. And of course, yes, you can always bring those up too with us, as part of your medical team on the GI side as well, if there's any concerns too.
Okay, awesome. So second question, this one is for Dr. Picaro. Are probiotics and multivitamins helpful in increasing growth?
Yes, it's a great question. So when I think about vitamins, we often are thinking about if we have sufficient levels for the body to function appropriately. And so if there are deficiencies, and we correct those, then that could potentially help with growth. And so that's the way I think about vitamins. It's not the case that if we use a lot of vitamins, that'll make growth better, right? So it's more about, okay, what do we need that's sufficient in order to grow well and for the body to function appropriately? The role of probiotics is a little bit more complicated. We do know that to some degree, the bacteria, viruses that are in our intestinal tract do contribute to inflammatory bowel disease, but it probably is quite a range, and in any specific person, any specific body, the role that microbiome plays in their disease process might be a little bit different. So it's possible that there's an opportunity there, but broadly for most patients, I can't say that probiotics is going to make a big impact on growth.
Okay, cool. So third question for Dr. Dotson. What is considered a longer use of steroids that would start to slow growth and delay puberty if there are a certain number of weeks or months or the number of times going on and off steroids?
Yeah, great question. Yeah. So it definitely depends on, how long you've been on steroids, what the dose of the steroids are, and then kind of where you are in that growth phase and puberty phase and how that is impacting things. So yeah, that's hard to really say. Now, typically, if you're on a short course of steroids, so say you have a current flare up and you're on, steroids, I'm just gonna like make up the usual, like kind of a regular case example. So, if there was a patient with UC and they were on their mesalamine and they had this flare up and it was their first flare up, so maybe we start them on, 40 milligrams of steroids daily, and typically we'll do that for 4 to 6 weeks, and then we kind of do a taper after that. So, typically you have that a little bit higher dose of steroid for several weeks, and you'll notice some, those steroid sort of side effects and things related to acne or sleep issues, or maybe some rounding of the face or things like that towards the end of that taper. And so those are some common, or moodiness, we'll see that too, or difficulty sleeping. Those are common ones. But typically we don't see, issues related to, like diabetes and cardiovascular impacts and osteopenia or porosis or things like that soon. Okay, those are usually longer, more prolonged types of things. And so most of the time when patients are on, that typical course of steroids, usually it's a matter of like weeks to a couple months by the time they get off of that initial taper potentially. And if it's just like that course, that's probably not going to significantly impact your growth and development. We get more concerned if we're needing multiple rounds of steroids, because what multiple rounds of steroids is telling me as a GI doc is like, the medicine you're on, is this really the right medicine for you? Is your disease really responding to this? Because if your medication's working well for you, you shouldn't keep needing repeat steroid courses to try to like put that fire out, so if that's the case, like I said, like using the UC example, so if you're on just a mesalamine product, you're not on a biologic for your UC, and we know like roughly about 30% of pediatric patients that have UC will do well and remain in remission on ASAs. So it's a great treatment option. But if you're having to do multiple courses of steroids in a year, yeah, that's probably like a sign to us that, yeah, we probably need to move on to a biologic, to treat that hypothetical patient for that example, because we definitely know that the steroids are going to be impacting, causing all those side effects, impacting growth and nutrition. We also know like the steroids is just kind of putting a band-aid on that inflammation. And it's not really getting at the source of that per se. And you're not really treating that disease and changing that natural history of disease. So we want to treat the disease. That's the most important part, because that's what delays or prevents those complications. That's what that decreases your overall like cancer risk, right? Because we know that chronic inflammation and that cell turnover is what increases colorectal cancer risk. So we want to make sure that we're controlling that inflammation. So I'm more worried about those multiple courses of steroids impacting the disease control as a sign. We need to change therapy. But then also once we start doing those multiple courses, then I start worrying, okay, like how are we doing with bone health? And so that's where a lot of times we'll end up checking like a bone mineral density test, like the DEXA scan. And so that's what that test can be helpful for. So if I have patients that have been on several courses of steroids in a year, definitely, so if you're looking at that, because we want to see, are we having an impact on that bone density? And if so, do we need additional, calcium supplements? Do we need additional treatment? Do we need to see a bone health specialist? And so sometimes those are a nephrologist or an endocrinologist. So those are usually the two that specialize in some of those bone mineral density issues. And sometimes we need to pull them into to help consult if we have those complications related to IBD.
Okay, awesome. So the next question will be our last question for tonight. So for either of you, once treatment starts, how long does it typically take someone to get back on track with growth? Is there a point that is too late for puberty and growth to catch up?
Whew. So from a catch-up standpoint, so I would say from a weight standpoint, probably not so much, but from a stature standpoint, so if it's later in puberty, and so say you get like a bone age, it looks like your growth plates are already closed, no amount of therapy that we're going to throw at you is going to help with catch-up growth, because your growth plates are already done. And if puberty is done, so say if you're 19 at that point, your growth plates are already closed, it's not going to help increase your stature. Now, if you're 19, so I'm just making up numbers. So like if you're 18 or 19 and your growth plates are still open and you have active disease, you just got started on a biologic, yes, then there's still some potential where you can get some catch-up growth from that standpoint. And so it does kind of depend on, where you are in that sort of normal range for puberty. And then if you're somebody who has a delay in puberty, so then like we talked about, kind of like you look younger than what you are, right? We were talking about that from like how nutrition can impact that, puberty, etc. And that bone age part is an important part of that question of how much potential growth can we see. And definitely for younger kiddos that are pre-pubescent, this really isn't as much of an impact, because you're catching them before puberty. Really, you're trying just to maximize their weight gain and their current stature, getting them back on track of where they are on their growth chart. And once they're doing that, then they're gonna fall in line and go through puberty like normal, unless there's flare-ups or things like that. So really, it's kind of those teen years, and that's really hard because most of our patients in pediatrics, they're diagnosed during those teen years. So that's the peak of when we see kids that get diagnosed. And that's why this growth part is so important. I think that answered all the parts. Let me know if it did.
I think so too. Okay, thank you both. This is a great discussion. I think we learned some helpful information today. So I think we'll pull the slides up one more time. Maybe. There we go. Okay. So, as our program comes to an end, on behalf of the Crohn's and Colitis Foundation and Improve Care Now, we encourage you to keep learning about IBD and to visit our helpful educational resources. So, Improve Care Now is a collaborative community where patients, parents, clinicians, and researchers work together to improve the health and care of children and youth with IBD. Utilizing the QR codes that you see on the screen now, you can navigate to their resources, stories, and support for IBD. And then you can join Improve Care Now's collaborative community with the QR code on the bottom right of this screen here. And again, this is recorded, so if you want to go back and look at it later, you totally can. So next, for our youth and parent resources, for our pediatric patients, the foundation has the IBD and Me Activity Center that provides interactive ways for kids to learn about their diagnosis, tips for talking to their friends about IBD, and information on how to manage their care. Teens can feel empowered through the Just Like Me Teens with IBD section that answers questions around nutrition, school, dating, and body image. And then next slide, Camp Oasis, the foundation summer camp available for children's grades 2 through 12, where you can connect with others your age and build confidence in managing your IBD. Again, scan this QR code and you can find a camp near you for next summer. And then if you're looking to connect with other patients and caregivers, the foundation offers virtual and in-person support groups. The QR code at the bottom right of your screen will help you locate a support group near you. The IBD Health Center is there to provide information and resources to patients, caregivers, and healthcare providers about inflammatory bowel disease. They're available by phone or email as well as live chat, currently available Monday, Tuesday, and Thursday. And then finally, to watch previous webinars and expert conversations, please visit the link crohnsandcolitisfoundation.org/MyIBD Learning. And I want to remind everyone again, please fill out the evaluation survey that will be sent after tonight's program. We really appreciate the feedback and it will help us plan future programming. Thank you again to our expert presenters and our IBD community for joining tonight, and have a great rest of your evening.